Good morning. It is Thursday, October 7th. Welcome to the Morning Medical Update. So glad you are with us today. We are live inside the Dolph Simons Family Broadcast Studio. Today we are talking more about the research behind monoclonal antibodies. They aren't just used to treat COVID-19. They are also used to fight cancer and help transplant patients. So we're going to hear from our research team on how they are used to target certain illnesses. But first, as always, let's get to Dr. Hawkinson, Medical Director of Infection Prevention and Control. Good morning.
Hi.
How do our numbers look today?
Yeah, numbers are still good, holding steady, as we've seen that large decreasing trend of cases around the metro area. Our cases of active infections have been down and have stayed down so far. We have 15 active infections with 5 in the ICU and 4 on the ventilator. We still have 36 that meet that additional recovery period. So a total of 51, and Hayes has 12 active infections and 6 in that recovery period as well.
Thanks for that update. Do we have reporters on the line today?
Yes, good morning. Cody Holyoke with Channel 9.
Hey, Cody, good morning.
Hey, everybody. Hey, so Pfizer just came out an hour ago, and I know that Dr. Stites was reading the tea leaves, and everything was kind of lined up for this, but they officially requested an EUA, emergency use authorization, for their vaccine for kids ages 5 to 11. And I'm curious what the doctors have to say about that. We talked a little bit about it yesterday, but is the goal to, obviously it's based on research and the timeline, but is the goal in your eyes try to get kids ready to go before the holidays really hit, or what's the thinking right now?
I think the FDA is not going to look at the holiday so much as they're going to just take their time looking at the information. Yesterday, a big news cycle around vaccinology, and certainly this question of getting the 5 to 12-year-olds, and then some questions about myocarditis of those 12 and older. So let's look at the 5 to 12-year-old stuff. I think it's a big deal. Pfizer did announce that today.
Yeah.
I'm very excited about that. We want to get these kids vaccinated. I think for a couple of reasons. First of all, the Delta variant does appear to be worse in children. We heard our ID colleagues from Children's describe that yesterday. Mm-hmm. And also because we think it'll help decrease transmission and help slow down this pandemic. So I think there are a lot of good reasons around looking at that information and saying, yeah, let's move forward with that. But I think it'll take the FDA, they'll do their appropriate work, Hawkeye, to get through all the information before they give an early use authorization. I think they're going to get it. Yeah. I don't want to say it's going to be right away, but I'm going to bet if they hold true to prior instances of about a 4-week time between when the data comes in and when they give an EUA, that I bet it does come out before Thanksgiving, and I bet there will be one. I think what we have to look at is that the other thing that came out in yesterday's news cycle around this is that some countries are saying, gosh, we're going to give 1 dose to those between over 12, and especially to perhaps males over 12, to help reduce the risk of myocarditis. When I look at that information, though, it's still pretty clear that the risk of myocarditis, severe myocarditis from vaccinations, is so much markedly less than the risk of coronavirus infection and even bad outcomes. And we heard that from our children's colleagues yesterday, that I think ultimately we'll stay with the 2-shot regimen for young people.
Yeah, I agree, and I think we have to be careful on our messaging here. The news media has to be careful on their messaging here. Myocarditis, yes, we heard about this yesterday with our pediatrics colleagues, but it continues to be extremely rare. It continues in the overwhelming majority of these cases that are associated with vaccine doses are self-limited. The patients do well. Very, very few other problems after that. So this is a very rare event, and I still do not think it should be a reason why people are hesitant about getting their children vaccinated.
And the rate was still incredibly low, as you point out. I was like, I don't remember the exact data.
Two for 100,000. I mean,
it's really low.
It's really low.
Then you take that number, Mario, and you say, okay, well, even less is the number of serious cases. Even less is the number who got hospitalized, and even less is the number who have. So it's close to 1 in a million or 2 million that actually have any sort of significant event from this.
Well, I think you also take in consideration COVID causes myocarditis, causes myocardial damage. And so that risk is much higher. And we've seen serious outcomes from that. Mm-hmm. We have not seen any serious outcomes from the myocarditis from the vaccine itself. So if I was a parent of, a young adult.
Aren't you a parent of some young adults?
Yeah, they're a little bit older adults. But yes, these young adults that are at risk of myocarditis, that's extremely rare. I know how they congregate, how they go out with their friends, and so on, and they need the vaccine to protect them.
Yeah, and my son is in that prime age group at risk of that vaccine-associated myocarditis. But I'm still so thankful, and he would have gotten it the first day it was available, and he almost did. He got it within the first few weeks, the vaccine, and I'm thankful that he was able to get it. He's been healthy throughout this. So again, I think that the risk of getting this myocarditis associated with the vaccine is so extremely rare that it is more benefit. The benefits so much outweigh the risks of that. So of getting your children vaccinated.
Definitely.
Other questions?
Yeah, just one more. I saw, we reported yesterday that the DeSoto, Kansas School District has a program called Test to Stay. And you're seeing testing at certain schools, but in this one specifically, if the test is negative, they can stay in school. School board members, and this kind of hit my ear a certain way, believe that this new program could potentially help ease mask mandates in school. I'm curious your thoughts on that, because I know that you say this is a multi-prong approach typically.
Yeah, I think we have to be really careful. Again, someday we'll learn from experience, right? And our experience has been that every time masks have come off, numbers went up, and we ran into trouble. And schools had that exact thing happen last year. And so you can say, well, can we test on a daily basis? Because the reality is when you say, well, I'll test once a week. Okay, that's great on the day that you're negative, but the other 6 days are wild cards. And so what I think we have to look at is say, how do we keep kids safe during the midst of this pandemic when they're indoors and in the classroom? And I know people say, oh, you're just a masker. Well, yep, you're right. I'm a masker. When you're inside and you're in a crowded situation, I take it. You can take your mask off to eat. I do that. We all do that. Okay, fine. But if you really want to reduce the risks and keep kids in schools, you wear masks until we have this pandemic under better control. And I would remind our audience that we are still building this airplane while we fly it. And we don't have all the answers. Just like on vaccination, we really don't have all the answers yet about how many vaccines we need, how often are they going to be, and how many vaccines do you need to have to reduce the spread of infection, not just serious disease. So we don't know the answer to that question. And in the meantime, what we do know is every time we've taken off masks, we've seen the numbers go back up, and the places where kids are in trouble and they're having to close down schools or put a delay in are all places where they don't have mask mandates. So if you want to invite the Delta virus in for lunch, breakfast, dinner, and if you really want to invite having to shut down your school again, then take your masks off. Regular testing is helpful. It is not a substitution for mask wearing, Hawk.
Yeah, no, and I think
Not that I feel strongly.
we have good data supporting this, masking in the schools, doing those other non-pharmaceutical interventions, and of course vaccinating all those eligible people that can be vaccinated is extremely important.
And this has happened around the world. I mean, countries have done the loosening of the standards, increased numbers in the classroom, and then the rates went sky high.
Unless you want to have like a 95% vaccination rate, because we haven't talked about Qatar this morning. It's a country there and in the Middle East. They actually have the highest vaccination rates in the world. They're much better than Israel's, right? They have 95% of their population has had at least one dose, and 90% have had both doses of vaccination. That is the highest rate in the world. Yep. And they had a great study that got published yesterday in the New England Journal, looking at, as they have a very strong public health system, they have a great system reporting the information and the data. And if you step back and you look at their data around vaccination with the messenger RNA vaccines, they started with Pfizer. Now they use Moderna and Pfizer. But even though the antibody levels waned over a 6-month period of time, down to about 20% where they started, protection against severe hospitalization and death, 95%. Right what we're seeing in the United States. And again, it's really strong data about the importance of vaccination and how well it can prevent really serious injury.
Yeah, I think that needs to be the story. Still packaged in that is the data that continues to support the fact that these vaccines, even months out from the vaccination, continues to provide protection against hospitalization, severe disease, and death.
It's key, and we want that to happen in kids too.
And these were with the Cutter article you're talking about was just that 2-dose regimen. So we haven't even talked about boosters for that age group or for that cohort as well. So.
I think the question for us on boosters, and reflect on this too, because you take care of a lot of immunocompromised patients. The question on boosters is, who should get it when, and I think the real emphasis from the FDA is really, we think boosters are going to cut back on disease transmission.
Yeah, I think the boosters are a home run for the transplant patients, the immunocompromised patients. Some recent data that came out and looking at patients that had solid organ transplants showed that there wasn't an adequate response really even after the second dose. It was 4 weeks after the third dose. And so I call it a series of shots.
Yeah.
And that's what you got to get if you are compromised. Your immune system is compromised. I think the rest of the population, when we're thinking about boosters, this is really to prevent more mild to moderate disease at this point that we're aiming for with the boosters for the general population. And those are completely different dynamics in terms of adequate efficacy in an immune-compromised patient versus the general population.
And Cody and Jess, just so you know, the reason that we can't find microchips for cars, do you know why?
Yeah.
Please tell us.
Because they're all in the vaccines.
Obviously.
That's been the whole struggle right now. You can't get a Toyota, you can't get a Chevy or a Ford because all those chips went into vaccines.
I knew it.
Yeah, that's a problem.
Other questions?
Not true, people.
Thank you. Okay. In case you didn't sense the sarcasm.
Yeah.
Can I tell you, on my way to work this morning,
Yes.
speaking of kids and masking, I actually had a field of fight between my two kids because my son stole my daughter's favorite mask.
Ooh, that would never have happened in my house. Constantly
Right?
did it every time
I was
back
like,
in the day.
I go, do you think you could find another favorite mask? So kids mask. They like to mask.
Yeah.
They even have their favorite mask. Who knew? Who knew that would happen?
I have a funny story to tell about that kind of thing sometime. I don't have to tell it right now, but I got a
Okay.
great story to tell
I like a
about
good funny story.
that. Funny story. My kids were young.
Do we have some other questions? Are we good? We're good back there. Okay, so we're going to get to community questions here in just a moment, but I wanted to officially welcome in Dr. Mario Castro. He is the Vice Chair of Clinical and Translational Research here with us, and I know that you're a big fan of Dr. Castro, so I know you're excited to have him
Let's
on.
not go that far. That's no tough. I'm a big fan of the Royals and the Chiefs and Patrick Mahomes.
Well,
but Castro's a good guy.
he's a good guy.
like him too, but I don't know.
But there's so many times that we'll be having a conversation about monoclonal
And I'll say,
antibodies.
where's Castro?
Where's
Yeah, what's
Castro?
Castro?
Where's
Get him
Castro?
down here.
Well, Castro
All right.
is here.
Yeah,
okay,
that's good.
so also joining us virtually, Amber Stiles. She is Senior Director of Regulatory Compliance and Risk Management here at the health system, but that's not what we're talking about today. She is also someone who has taken part in the monoclonal research. So we're going to chat with Amber here in just a few moments. Good morning to you, Amber, by the way. Thank you for being with us.
Hi, Amber. Amber's the best.
I
morning,
know.
Yeah, Amber is the best.
Everyone loves Amber. Okay.
I know. She's one of those people who you like. Anytime we get a little bit of trouble, or we have it's like the joint commissions coming in, where's Amber? Where's Amber? Get an Amber in here.
Well, we're excited to talk with you here in just a moment. Okay, so Dr. Castro, let's get to you. So research. Let's talk about the research that's being done on monoclonal antibodies here.
Sure. So first, let's say what a monoclonal antibody is for those not familiar with it. So your body builds natural immune antibodies. Every time you encounter something in the environment, something you don't see, your body doesn't normally see, such as infectious particles, things that you inhale, our body's doing this every day. So what monoclonal antibodies are taking that chemistry that our body normally does it and does it in the laboratory to develop protective antibodies specific to the spike protein that's on that virus. So you can think about that spike protein. I kind of tell patients it's what punctures your cells. It's what gets that virus inside your body. So what we can do is cover it with this antibody specific to that spike protein and protect you from that virus inside your body, inside your cells. And so the difference between the monoclonal is it's very specific to that protein, and then we're also studying what we call a polyclonal, which is a mixture of various antibodies against the virus. And so all these approaches have been studied. Now we've had monoclonal antibodies approved under the emergency use authorization almost a year. We're approaching almost a year with the first one that was approved. And what we've learned is we need to use a combination of antibodies. We need to use 2 monoclonal antibodies, and these are very effective at decreasing the severity of the infection once you have the infection. They're very effective of shortening the length of the symptoms that you have. The most recent study showed that monoclonal antibodies decreased the symptoms by 4 days which is huge in the field of infections, and also prevented those infections from going on to serious hospitalizations. So the monoclonal antibodies that we currently have available, the two different manufacturers, allow us to provide this as an infusion. We usually like to get it in the early stages, and that's key. We like to do the treatment within the first 7 days of a positive antibody test, and want to make sure that you're tackling this in the early stages before that virus has replicated. So what we understand now is that the severity infection is directly related to how much that virus has replicated in your body. And so if you wait too long and you're in the hospital and in ICU, that's not likely the time that a monoclonal antibody is going to help you at that point. So the really important thing is once you start developing that symptoms, you get your test, think about whether or not you should go ahead and get a monoclonal antibody to really combat this in the early stages.
FDA approval, when will that happen? And how important is that for people wanting to get it? I would imagine if people needed it, they'd take it.
Sure. So these are approved under the emergency use authorization, as I mentioned. That has been adjusted as the data comes in. And so when you think about the overall approval for these monoclonal antibodies, the FDA wants to see thousands and thousands of patients' data being treated in a period of time of observation to see what the long-term side effects are from these. And we're not there yet. And so the data has not been really accumulated, cleaned up for the FDA to really understand whether or not to give it full approval. But we're treating patients with this every day now here at KU, and I definitely have seen it make a difference. And so I think we're at that stage where we need to study all the different ways we can treat patients with COVID, whether it be an infusion, an injection, or an oral pill.
And can I just say a couple of quick points around? So yesterday, both there's two different. There's the Regeneron version and there's the Lilly version, I think, with bamlanivimab, another one, and the data from both of those looks remarkably good for reducing hospitalization.
Right.
So I think for our listening audience, even though it's an EUA, the reality is that these drugs look incredibly effective, and this concept of antibodies is certainly not new at all. I mean, we use them in the lung transplant population all the time to prevent rejection, right? We give different kind of things to help prevent disease, and so I think that folks, we don't use enough of this. Is my sense of it when we see the amount of severe disease that's coming in the hospital. I think, man, if these people had gotten monoclonal antibody therapy, they would have done so much better.
Yeah, I agree. We use this every day, as you mentioned, all the way from patients with arthritis, patients with asthma that I use biologic monoclonal antibody therapy, patients that have organ transplants. This is something that we are very accustomed to use. It is something that we have a lot of safety data, recent data, even with pregnancy that has looked at use of monoclonal antibodies. So we know how to use this appropriately. We have now almost a year's experience in using this here at KU, and so I'm very comfortable starting this after we assess patients early in the disease process.
Any concerns about a shortage as more and more people turn to this?
Hawkeye, maybe you can address that in terms of our supply and demand here.
These are produced. They aren't taken from patients that have recovered. We heard Dr. Barr give a good explanation yesterday. And so there could always be those supply chain issues. Right now, I believe the government is helping with distribution of these. So some areas may have a little bit more problem than others. I think they are really trying to focus on those places that are hardest hit right now. But right now, we have been really pretty good here.
Yeah, I think
at the health system.
Supplies are good because they're underutilized.
Right.
If people were all use them when they should, we probably would have a supply chain problem. But we don't have a supply chain problem because they are underutilized. And you can call your physicians, and if they can't get you in, you can call us. We can help direct you. Truman Medical Center has a big monoclonal antibody infusion on the Missouri side program. I think just about everybody's got a program going, and I think it's just incredibly important for people if they have severe disease. And the need will arise again, just to say, mask mandates got extended in a number of areas yesterday, and that's great. I think that is really the right thing to do while we continue to get this thing under control. But the numbers keep falling, and if people get impatient and want to take masks off, we'll see a spike, and then we'll have even more need for monoclonal antibody therapy.
We're going to get to Amber Stiles here in just a moment, but Dr. Castro, will you just take a moment just to talk about trials here in general and the importance of participation in trials?
Well, Amber is, really an example of that. So when we launched the monoclonal antibody study here against COVID almost a year ago, Amber was one of our first participants, and that led to the first emergency use authorization approval. So this was really trying to get on top of this pandemic very early, and it was directly related to participating in a clinical trial. And so we have clinical trials here in cancer, we have clinical trials here in a variety of different health problems. And so I encourage people to think about it. If you have a little bit extra time on hands, if you're able to participate in one of our clinical trials, it really contributes to our knowledge in advancing the science so we can get new treatments available to our patients. I'm amazed every day when I talk to our participants in our studies, and I say, why are you participating? Well, I know this might help somebody down the road, or I had a nephew or a grandchild that was impacted by asthma or by another problem, and they want to help them. And they think that this, they understand that participation in there is so key. The other thing I've learned from doing this is that our patients that participate, they learn so much more about their bodies and about their disease because they get so much more information by participating in a clinical trial than they do in a regular, very busy clinic. Often you don't get all those answers that you want. In the clinical trial, you have specialists that are working with you that deal with this every day, and they provide that information to you, and you get return on your money. Even if as I tell them, a lot of our studies, you may get placebo just by the luck of the draw. That's how we have to do the science. But that participation in the study itself is so important to you.
It's still part of it. It's just
Yep.
one way you can give back to your society and your community. I love that. If somebody wants to know if they qualify for one of the trials that we're doing here, how do they go about finding more information?
So we're going to show a couple contact points for the Recover trial, which we'll talk about shortly. Christina Pantalone is your contact there. Christina is screening for our Active 2 trial, which is the trial with monoclonal antibodies and other treatments against outpatient COVID, the one study that Amber participated in. But we are about ready to launch the Recover trial, which is looking at long haulers, looking at long-term effects from COVID. And that should be launching here later this month. The other area that you can participate is in our cancer clinical trials. The website is there. It's a wonderful website. You can type in, hey, I have prostate cancer. Is there any trial for me? Whatever it is, you can look in there. There are hundreds of trials that are available here at KU. And I'm quite amazed. In fact, I enrolled my mother in one of them with bladder cancer, and it was just outstanding, the care that we received, the information that we got, and the communication made my mother, who's 88 years old, very comfortable in participating in the clinical trial.
Fantastic.
Can I just say two quick things?
Yeah.
So first of all, Mario, we do this big CTSA, this big Clinical Translational Science Award. It's a huge national award, and you just got a score that was unbelievably good. You're the head of that, and here for this place, and it involves a bunch of other places who are collaborators with us. But Mario's the head of it, and you guys, just to say, you guys got a really amazing score on that grant.
Yes.
So that's a
Yep.
really this is something I know Mario lives and breathes every day. So that's a really big deal. And the second thing is the Cancer Center program. If you step back and said, what are the two biggest research programs at KU? Cancer and the CTSA that Mario heads. And I think that both of those have as their core that you have to recruit patients in the clinical trials to try and advance care in the United States and the world. And so we really have to encourage people to do things and be involved in the trials that Mario's talked about in our Cancer Center program. People like Amber stepping up. It's all about that, Mario.
Correct.
All right, let's bring in your girl, Amber.
Yeah, she's awesome.
Hey, good morning. How are you?
Good morning. Sorry, mute button. I'm good. Thank you.
Well, first of all, I just want to find out how you're doing after recovering from COVID. Just tell us a little bit about that, first of all, that experience.
I'm doing much better. A few months ago, I was able to speak on morning media, and at that time, the brain fog and the fatigue was still pretty significant. It's really subsided. I still need a nap midday. Weekends, I take a nap literally every Saturday, Sunday, which is not my norm. But it's much better, and the fog I think is much better. I will say that I've learned to give myself a little grace in terms of my endurance, and I used to work out regularly. I completely stopped doing that with COVID, unfortunately, and then I caught COVID, and it just was not able to get back into it. And so giving myself a little bit of grace and understanding that 15 minutes is better than no minutes, and trying to just do a little bit every day to try to help with that fatigue and the fog.
Well, I can appreciate you trying to inch your way back to life. I mean, these are those things we talk
Yes.
about. It's not just getting COVID, it's how it ultimately affects you long term.
But people should hear in this testimony that Amber is giving us and realize this is yet another. It's not just hospital. This long haul thing is very real. And Amber, this is a great. Amber bearing witness on how important and how real it is.
And Amber, how long ago did you have COVID?
I tested on October 30th of 2020 and my positive results came back on Halloween.
Yeah, and here we are, a year out. So, yeah. So tell me about your experience of receiving monoclonal treatment. How did you feel afterwards? Was it immediate? Walk us through that process.
So I, on the 31st, when I knew I was positive, I reached out to the study coordinator. I knew about the study through a friend and reached out to the study coordinator, who replied right back within hours, and that was a Saturday evening, set up a call for the next day. I was able to virtually go through the consenting process. He went through it very thoroughly, answered all my questions, and then set me up for that Monday. It was really pretty quick. Set me up for that Monday to come in and do the infusion. They met me at the door, again, just explained every little step of the process. It took about 4 hours for the infusion and the monitoring and whatnot. I would say, so I came back home that day. Fatigue was probably one of the worst things for me when I had COVID. I literally slept 20 hours that Friday, Saturday, Sunday, like 20 hours a day. And so I came back home, I slept, I got up that night. I felt a little better, but I was also losing my taste and smell at that time. And by the next day, I kept thinking, is this mental? I just felt different. I wasn't as tired. So I couldn't sleep 20 hours. I was still sleeping a lot. I was congested, and then my taste and smell was completely gone by that Tuesday. But literally within a few days, I expected not to get it back for a while. Within a few days, it slowly came back. I was stuck in a room and very bored by day 5, I think. But I truly believe that I got the antibodies because my COVID journey was, I feel like, pretty short compared to others. And when you contract COVID, I know I can speak for myself. You literally sit there waiting for something to happen. You're just like, am I gonna be okay? And so I felt really blessed to be able to participate in the study, and I felt better within a few days.
Well, thank you, first of all, for stepping up and being a part of that trial. And just what would your message be to somebody who would want to, A, be part of a trial, and two, take monoclonal antibodies?
So when I wanted to participate in the vaccine study, but time was not on my side. When Dr. Castro says, you have to have some time. Well, you have nothing but time when you're sitting in a room with COVID. And so, so I jumped in there, and what I knew was that a lot of minorities were, we were losing a lot of lives, period. But minorities and as African Americans just are very hesitant to participate in things of this nature. And so I thought it was important for me to be able to participate and tell my story. And I tell my story to anyone who will listen. I think that's important as well. I'm not embarrassed that I caught COVID. It happened. And here's what I did with that. We need that research. And I think a few weeks into my participation in the study, it was actually approved for emergency use, which also made me feel good because I'm participating in something and it's working. So that's what I would say in terms of participation. If I'm thinking about, I think your second question was if someone wants to participate, I think ask a lot of questions. And during the consenting process, again, it was very thorough, what I went through. And I had a lot of questions, and all my questions I felt were answered to my satisfaction. Don't shy away from participation. I knew going in that at any time during that infusion, if I got worried or scared or felt bad, I could stop at any time, and you can stop it at any time you want to. But I went through with it, and I'm really glad that I did.
My phone is literally blowing up with so many questions for both of our guests, and so Dr. Seitz, I'm gonna let you take the wheel for a quick minute so I could field through some of these questions, and maybe you could talk with Amber a little bit.
Yeah,
I'm sure you have questions.
I have a few for all of these guys. So, Amber, are you vaccinated now?
I am. I was vaccinated in January.
And how did that go? Because you had COVID, then you got vaccinated. Did it help your fatigue and your brain fog at all?
Yeah, a little bit. Again, that's just been a process, and I don't know about this fatigue. And people tell me, oh, with your job and you have kids at the house, and well, I've always had that, and I wasn't like this before, and so I think what the vaccine did for me truly was gave me a little bit of peace. A lot of peace, actually. I still mask, and every time I walk into a store, anywhere I go, if I'm indoors, I'm just masked. I don't care. I don't pay attention to anybody looking at me. Sometimes I'm one of the few that's masked, but to me that doesn't really matter. But the vaccine, it wasn't even a thought. I just did it.
Yeah, I'm with you entirely. We just do it because it makes so much difference that it does bring peace of mind. Mario, you mentioned this RECOVER trial.
Sure.
What's going on in the RECOVER trial? And talk to us a little bit about that, because we just heard this testimony from Amber. You really don't want to have long haul syndrome. She's had it, but we're developing therapies for it.
Yeah, so RECOVER, which is a new trial sponsored by the National Institutes of Health, is about to be rolled out across the country. We're enrolling 17,000 patients that have had COVID into the study. And the goal really is to understand what is causing these long-term symptoms that Amber nicely mentioned in terms of, this virus, for some reason, it causes this attack on the brain system, on the nervous system, and it gives this brain fog. Well, how do you diagnose that? What are the right tools we as physicians need to use? How do we monitor it? And then how do we ultimately treat it? We don't know any of those answers right now, unfortunately, Steve. And so this is the challenge. And so Recover is going to help us do that. We're going to be enrolling here at KU here shortly, within a couple weeks. Certainly reach out and contact Christina. If you have an interest, we'll reach out to you in a couple weeks once we finally get our IRB approval. The idea behind here is, if you have fatigue, we're going to do a battery test for fatigue. If you have shortness of breath, we're going to do tests that are right for shortness of breath. And when you do that across the country, across different populations, as Amber mentioned, we need to know, how does this impact Black individuals? How does this impact our Latino population? Then we can know what treatments potentially will work. And we're really right at that cusp of understanding what's potentially causing these symptoms, and then we can develop the treatments for it. So if you're experiencing any symptoms in regards to sequelae, we call it long-term effects from COVID, reach out. We'll be happy to get you to participate in the Recover trial. 588-3851, 913-588-3851. And, you'll be not only learning a little bit about yourself, but you're going to help us contribute to the next step. What are the worldwide numbers, Hawkeye, for COVID? We're at over 5 million, I think, 6 million.
I thought it was 7 million, but yeah,
or 7 million.
Approximately
Yeah,
a very big number. And if 10 to 30% of
yeah,
the people
exactly.
get long haul syndrome, that's a big number.
I mean, we're looking at probably the biggest public health issue that we're going to have over the next decade.
Yes.
And when you think about persistent symptoms and disability related to those symptoms, this is going to occupy our lives for the next decade. And so if we can start working today on getting answers for that, that is going to help us down the road.
Yeah, I mean, from the Johns Hopkins dashboard, 236 plus million cases, 4.8 million total deaths. Again, I think we all have to assume as well, and I think it's a pretty supported assumption, cases and deaths as accounted here is probably lower than what it actually is.
And if it's really 236 million, if only 10% had long haul syndrome, well, it's probably higher than that, right?
Yep.
That would be 23 million people. Oh my God, that's a really big number. And we just don't have that in any other disease type right now. And it's in just a very overly simplified manner. We sit back at the hospital and say, okay, how many hospital beds are we going to regularly fill with COVID-19 patients? Because we're 2 years into this, right? And the reality is today we have 51 patients in beds. That's our single biggest discharge diagnosis. Mm-hmm. And 2 years ago it was 0.
Yep.
And you sit back, you think about that, and you're like, that's like 2 wards of the hospital. We were full before. Now we're full. Plus we've got another two entire. If you try to wrap your mind around it, it's hard to do, I think, and it's hard to do. And the worst part of it, so much of it is preventable. If people will get vaccinated, use monoclonal antibodies, call us about that, it will help immensely. But what about the oral pill, Mario? What do you think about this coming oral pill? Because you've been in this research for ways to try and do it, and you actually, I think, didn't you have a pill or something you were looking at?
Yeah, so we were studying an oral pill medication in the ACTIV-2 trial. The ACTIV-2 trial, the way we do it is we study 100 patients in each arm. We then close the study, and we analyze the data. And for the oral pill that we were studying, it did not meet the primary endpoint in terms of efficacy, and therefore it did not move on. So currently what's moving on in ACTIV-2 is a new set of monoclonal antibodies that can be given as a sub-Q injection, just an injection under the skin, just like we do with insulin. And there is a inhaled therapy that's moving forward. So our hope, though, eventually we will be able to test additional oral therapies. What was just released this past week was from Merck, a new antiviral drug as treatment for COVID infection. And this is, again, in the setting of mild to moderate COVID infection, and showing that there was about a 50% decrease and preventing those infections to going on to serious COVID infection and hospitalizations. Now, as Hawkeye's been telling us all along through this pandemic, we're early in understanding what this medication is, what the side effects are, and so we haven't even seen peer-reviewed data in terms of this medication. The data is certainly being reviewed by the FDA. We need to figure out how this oral pill is going to be used in the future. We don't know all those questions yet.
Yeah, and I'm always skeptical of, oral antivirals. Certainly for HIV, we have shown that you need more than one drug because resistance develops. There's obviously, we know how variants arise with coronavirus. We know how resistance develops, so we have to look at that as well. Certainly there are some viruses and viral agents that we use as single therapy. But I think that is the issue you run into with antivirals as well, is are you going to have to provide a combination therapy, or is one drug going to be good enough? So.
All right, Jess, I bet there's a lot of questions
There
out
really
there.
are. Can you guys stick around a little bit so we can get to some of our viewer community questions? What kind of time do we have, doctors? What's going on? Can you answer
I can
some?
stay around a little
Sure.
longer. Yeah,
Okay,
yeah.
just stop me when you gotta go,
Yeah.
because I'll just keep going. Okay, so let's get to some of these. Nigel has a very specific question for you, Dr. Castro. Have all the drugs from the active 2 phase 2 trial been moved to phase 3 yet?
So some have not moved on to phase 3 because they were not shown to be effective, and we are waiting for 2 more sets of drugs that are being reviewed right now. Their safety data, the inhaled therapy by Synergen, and then a mixture of monoclonal antibodies made by BMS. Those are currently being reviewed. We don't know yet
Gotcha.
if they're going to move on.
And Neil wants to know, do we have to meet certain high-risk categories to qualify for the monoclonal antibodies?
So I'll talk about what we're doing in the study, and then maybe Hawkeye, you can
Hawkeye
address,
knows it, yeah.
from the health system standpoint. But what we're doing in the study is the most important criteria is that you are within the first 7 days of your positive diagnosis. That is absolutely the most important thing, because we know of all the treatments, the earlier you start it, the better results you're going to get. The other thing is you have to have some constellation of symptoms. So if you have shortness of breath, or you have the chest tightness, you can contact us and we will start to screen you for this study. It is, everybody is a little bit different in how it impacts you. So as Amber mentioned, sometimes it's losing that taste or that smell, and then you start to develop that sore throat. Well, don't wait until it moves beyond that. Go ahead and contact us because the monoclonal antibodies can be used early in the treatment with that constellation of symptoms, and that's when it's most effective.
Yeah, and as far as other high-risk situations, certainly we take that into account. We heard Dr. Barr this week talk about that, especially as sometimes our supply is good. We have been using more, so our supply is down. Can we get more? But for the most part, we haven't put that many restrictions on being able to get the monoclonal antibodies. We certainly want to reach those people that are at a higher risk of hospitalization. Those people, again, older age, immunosuppressed, other comorbid conditions like obesity, diabetes, heart disease, lung disease, kidney disease, those types of things. But we take all that into account in our active screening.
And everybody 18 and above?
12.
12 and above.
Christy wants to know, is this treatment for anyone with a solid organ transplant?
That would be one of the high-risk categories.
Yeah, that would
Yep.
definitely be
Okay,
a high risk.
absolutely.
When you talk about organ transplant or bone marrow transplant, at that point you always have to think and assume this person is going to be on immunosuppressive drugs so they don't have rejection from those transplants. So, that is why immunosuppressed would fall under that.
And I know I've sent some folks down there post-transplant who have gotten monoclonal antibody therapy.
So Gene says he feels there's some confusing information on long-term efficacy of vaccines months after the vaccination. Dr. Stites seems to say 98% effective against death and long-term illness. I've heard others say 80% against hospitalizations and serious illness. I've heard Israeli studies with 47%. Where can you find the most current information about the efficacy?
I think the question is what you have to be careful about. Are we talking about disease transmission, which is the 20 to 40% range data. The Cutter data was, I think, down to 20%
Yeah.
from Pfizer-BioNTech at 6 months for disease transmission. The next question is hospitalization, and the next question is ICU and death. And so really that's why the data seems confusing, is the stuff that says, well, it falls to 20 or 30, 40% of that is really about disease transmission. When you start talking about hospitalization, that's more the 80 to 90% stuff. And when you start talking about ICU stay and death, that's more the 95 to 98%. I think, Hawkeye, that's how I would describe it. It's those three different areas.
Yeah, so when we do hear those very low numbers of efficacy, talking about the vaccines, I think we should remember that those studies, for the most part of what I know, those are looking at anybody testing positive at all for the disease. So we really want to throw those out. These vaccines are really made to prevent hospitalization and death. And I think the bulk of the data that we have, very good peer-reviewed data, just as Dr. Stites said, you really continue to stay in that 85 plus or more efficacy protecting against hospitalization, severe disease, and death. And that is for all age groups. Now, it might be a little bit lower for those over 65, but we've seen, well, that is why additional or booster dosing is recommended. The same thing with the immunosuppressed. So just as Dr. Stites said.
I think that's really important, is that you look at the disease population and say, even if you've been vaccinated, let's say you're preventing its hospitalization, well, that's 80 to 90%. Who are those 10 to 20% of patients who are coming in? And largely, based upon our own information, we look at this question on a daily basis. For the majority of the patients, the overwhelming majority of the patients who are just coming to the hospital once vaccinated with COVID-19 are people who you look at it and you're like, gosh, you were really high risk for a bad outcome from COVID-19 to begin with. And you may not have had as good an antibody response because you're over 65 or you're a transplant or you're getting chemotherapy. Then when you go even to the next step and say, who's dying from COVID-19 after vaccination, it's a really small percentage. Again, that's at 2 to 3% of patients. And those people are, we just aren't getting otherwise healthy people vaccinated dying from COVID-19 in our numbers. That is almost entirely a population of patients who either had an organ transplant, have active chemotherapy, or have lots of comorbid diseases. Their severe diabetes out of control with heart failure and with emphysema, like a combination like that. And so that's the patients we know are the ones who probably are going to really need the boosters the most, so that they will help protect against that. And again, we have to just remind everybody, while the plane we fly is not the one we started with, where Hawkeye and I were pedaling in the air, we still it's still not completely constructed. And so meaning that we are building the airplane while we fly it, and we are still learning, and it's people like Mario and Amber who are helping us learn more and more about this disease.
But I'd like to jump in, I'd like to commend the person that asked this question, because
it's a great question.
I think for the general population, it is very confusing. And I think there has been a lot of confusion around the messaging. So I think the big bulk of our message is that these vaccines, the overwhelming supportive data about these continue to support the fact that even 6 months, 8 months out, they continue to provide good protection, 85% or more above about that risk going to the hospital, severe disease and death. Even this, and I think it's hard because of the mass media, their messaging, their headlines, which do not tell the whole story of the actual data. So, for instance, I saw waning immunity in men compared to women, or waning immunity and that's from one of these New England Journal of Medicine articles. Well, if you look at some of the data, that article was not really looking at infection. That was just looking at the dynamics of how high do your antibodies get and how quickly do they fall. If you look more at the results, it shows that over 4,800 people were recruited for that study. They had 25 infections that they were diagnosed by PCR or antibody. So out of 4,800 people in that study, only 25 infections.
And then nobody gets really sick and nobody dies. And
Right.
that's if you go look at the Cutter data, it's the same thing.
Yeah.
Yeah, the antibody levels may wane, but the hospitalization and death does not increase. And that, I think, is just a testimony to that we have multiple levels of immunity that are induced by the antibodies. Other fascinating thing, just to really make things a little, it's kind of fun to trying to wrap your mind around some of this information. But there's an early report that patients who had SARS-CoV-1, not CoV-2, still have antibodies 10 years later and have a remarkable response to immunization against SARS-CoV-2. So good, in fact, they think it may protect against coronavirus more broadly. It's fascinating stuff.
A few more questions. Sandy says, what's the difference between monoclonal antibody and Regeneron?
Regeneron is manufacturer of one of the monoclonal antibody mixtures that we use. So they make a monoclonal antibody. They make 2 monoclonal antibodies that we use to treat the outpatient COVID infection, and we have to treat that early. But they're the manufacturer of that.
And I think, we have a cartoon image, and this, I've seen it before. This one was taken from the website Imperial College London. I think it's probably out on several websites. But this is just a cartoon computer-generated depiction of the virus and then antibodies attached to the virus. So this is just something to give you some sort of visualization. But you can see the antibodies there bound to that round thing in the middle, which is the spherical thing, which is the virus. So that's just somewhat how you can contextualize what's kind of happening in your
And when you
body.
wrap those antibodies around it, the virus gets neutralized.
Yeah.
It looks like Star Wars.
I was thinking it looks like the Kansas City Chiefs' new offensive line. Let's block that sucker out, people. Let's run the ball.
Simon is asking, Dr. Castro previously mentioned a potential upcoming trial for severe asthma. Wondered if he had any updates on this, if you could update us on that. Do you have any info?
Yeah, that'd be great. So we are launching a study sponsored by the National Institute of Health called PRECISE. And so we were talking about, in some of these chronic diseases, we have great treatments, but there are a subset of patients that just continue to have problems. And these are my severe asthma patients that represent probably 5 to 10% of asthma patients out there. And we need to find out new treatments for them. And so PRECISE is studying 5 new exciting treatments that potentially people can qualify for. So if you're interested, please contact us. We will, consider you for that trial. We're enrolling patients across the country, 600 patients across the country into that study. And as Amber mentioned, we go through that very careful consenting process so that our patients understand, what exactly you're getting into. We're not stopping what your doctor is giving you. We are adding to that therapy in order to figure out what can work, what's most effective for our patients.
I'll give the last question to Donna, and maybe Amber, you could start us off. What do you say to people who distrust the vaccine but think that we should treat people with things like monoclonal antibodies?
Well, one, I say trust the vaccine, get vaccinated. The monoclonal antibodies, once you contract COVID, I was much more worried about what would happen to me from COVID than I ever was in the trial with the antibodies. And so I would just say to talk with your physician, listen to the experts. I'm very blessed to be surrounded by some amazing physicians, and I trust you all immensely. And so talk to your physicians. The assessment that was done on me, they looked at what medications I was on, any other illnesses or things that I was going through to make sure that I was appropriate for the study. They're not going to give antibodies to an individual that shouldn't have them, which I don't even know who that would be. But trust the science and talk with your physician.
Dr. Seitz, don't sidestep the vaccine and just rely on the treatment, correct?
Yeah, no, please get vaccinated because you don't want to have to put yourself in a position to take the treatment. The treatment is a last resort kind of thing. And let me tell you, y'all out there don't know Amber. I know Amber pretty well because we work with her a lot every time there's a bump in the road here about anything. And Amber's the one we bring in to help save us or rescue us. And she's one of the smartest, best leaders we have. And so when she says trust the science, I'm going to say trust Amber.
Love it.
Because that's what we do every day.
Love it. All right. Thank you guys for sticking around for those and great questions, and I'm going to go through them and we'll hold them off for tomorrow for Follow-Up Friday. So before we get to our final thoughts, I just want to take a moment to talk about this guy, Dr. Barney Graham. Dr. Graham received his medical degree from KU School of Medicine, but you might recognize him from this shot. This is from the Times 100 most influential people. He was also recently on the cover of the Washington Post. Dr. Graham is considered the pioneer architect of COVID vaccines, in particular his work with Moderna. So in just a few moments, you're going to hear from him. So stick around for that. But first, Dr. Castro, thank you again for being with us. I am a big fan of yours.
Oh, thank you.
And
jeez. Oh, my gosh. Give me the conversation.
right? Okay, so final thoughts.
Well, I do want to give a contact information. If anybody has severe asthma and would like to participate in our severe asthma trial, please contact Fatima. Her number is 913-945-8199. That's 945-8199. We have a lot of different severe asthma trials that, we are really feel unique here at KU that we're able to offer these potential exciting trials and treatments to our patients that you can't get everywhere. This is really special. And I think, as Amber mentions, when you participate in a clinical trial, you're not only helping potentially yourself, but you're going to help others that are affected by this disease.
Amber, final thoughts from you today. What do you want us to know?
I would just again say that participation in a trial is it's needed, and we need people to step in and say, I'll do this. Again, the consenting process is very thorough, and at any time where if you get concerned and want to step away from it, you always have that option. And so really consider participating in those trials. I wrote down the number for the Recover trial. And then lastly, I just cannot say it enough, get vaccinated. A number of my very close family members are not, and it terrifies me every single day. I have a cousin who's been on the vent for a month, and she's in her mid-30s. Not vaccinated. It is just so important, and I'm trying to say this without getting emotional, but it's just so important, and my family is extremely important to me, and we don't get to see each other like we used to, even with everything that's happened, and so it's just so important for the vaccine.
Amber, thanks so much for sharing that part of your story. And it is very emotional, I know. Guys, if you would, before we get to Dr. Hawkinson, could you put back up the information for the trials so that if people want to participate, they can? Dr. Hawkinson, your final thoughts today.
Yeah, well, I'm glad Amber's well, and again, take comfort in understanding that we have more evidence showing that those people that were infected and then got vaccinated probably have better protection and the ability to identify and neutralize current variants and any variants that may come down the road. And again, I think we are seeing good data every day, Dr. Stites. Some of it's granular, some of it is big picture. I think it's all helping to inform us about our immunity, about the virus, but really take this for the big picture is that all of the data continue to support the fact that the vaccination, even months out from vaccination, from the second dose, continues to provide great protection and reduce your risk of hospitalization, severe disease, and death.
Hawk, you said it so darn well, and I don't know that I really even have a lot to add today, other than in this world you decide who you can trust, and that's true about all of our relationships, right? Who do you trust? Who do you listen to? And I would tell everybody out there is no one at KU you can trust more than Amber Stiles, and I know I do. I know we all do. Everybody out there needs to as well. Ultimately, the battle against COVID is a battle about trust. And who do you want to listen to? People who have spent their entire lives investigating and trying to analyze this, and patients like Amber who tell their story, all that made up stuff out there. Who do you trust? Because the choice you make will determine your fate.
Well said. Thanks to our docs and our viewers for sticking around for this conversation today. Tomorrow we're going to be back with Follow-Up Friday, so we'll include some of those questions we didn't get to. Amanda Kapler is going to also join us. She's the Director of Infection Prevention and Control. She's going to join us from our Great Bend campus to help us answer those. Dr. Hawkinson will be here as well, so we'll see you tomorrow. Here now, though, is Dr. Barney Graham.
choices to take the vaccine or to get infected. Everybody on Earth is going to be exposed and infected with the virus at some point over the next several years. And if you get infected and you don't have any vaccine protection, you have a 5 to 10% chance of being hospitalized or in the ICU. You have a 20 or 30% chance of having long-term symptoms. If you're worried about some kind of side effect from the vaccine that happens once in a few million, if you let yourself get infected without vaccine protection, your side effects with the virus infection is going to be a few out of 10, not a few out of a million. And your chances of dying are relatively high with the virus infection, especially if you're older or have some of the conditions like hypertension or diabetes or obesity and things like that. The vaccine immunity is much better than the infection immunity. And especially people who have relatively few symptoms, they often do not make a very strong antibody response and don't trigger enough B-cell memory to really have strong immunity. And so in people who have been very, very sick, who've been in the ICU and then recover, some of those people have good levels of immunity. But in general, if you look on average, the vaccine immunity is at least 3 or 4 times higher than infection immunity. mRNA is a type of vaccine that is very elemental and simple. It's one of the simplest types of vaccines that could be made. It never goes into the nucleus where your chromosomes are, so it can't change your DNA. It doesn't change your RNA. Makes a protein that's then there for 5 or 6 or 7 days. And then the protein is gone and the lipid is gone and metabolized quickly. So within a few hours or days, everything to do with the vaccine is gone out of your body or totally broken down and metabolized. So the only thing left now is the memory of that protein, and the antibodies that see the shapes and surfaces of that protein will give you protection if you ever have to deal with the virus in the future. The technology for these has been developed over the last 40 years. And there's a 1-year story, but there's also a 3-year and a 7-year and a 12-year and a 20 and 40-year story. And the data we have for this vaccine is probably more extensive than just about any vaccine I've ever been involved in over these last 35 years. I just want people to understand that the antibody treatment is effective, thank goodness, but it all is coming out of the same type of technology that led to the development of these vaccines. And so preventing infection is just a lot more effective and cheaper and everything easier than waiting to be treated.
Subscribe to our morning medical update and open mics with Dr. Stites podcasts. Now everywhere podcasts are available.